This case presents as a classic anterior hip impingement, but what you're seeing here actually isn't a hip problem. Let's watch this squat closely. What we see here is to get into the basement position, he aggressively leans his torso forward. His arms are stretched out, his chest is over his thighs. Now, why is he doing this? It's to counterbalance his lack of ankle dorsiflexion. You'll notice his toes are actually lifting off the ground, and he's doing this so as to counterbalance himself so he doesn't fall backwards. That forward lean is not a postural cue, it's a survival strategy in this case. Now let's think about what that does for the hip. More forward lean, more acute angle at the hip, more compression at that hip. This is how ankle restrictions cause hip impingements. The hip pain is just where the problem shows up. Now let's talk about the compensations. You notice his knees are flailing outward, way past the line of his feet. Now most people would say, well, there's tightness on the outside of the hips, but watch here as I try to correct that. As I bring the knee closer to the midline of the foot, the pattern breaks and he has to come out of the squat. Why? Because his ankle just doesn't allow it. So what's the takeaway here? You don't fix a squat by trying to fix the squat. You fix the squat by fixing the joints that are involved in the composite movement of the squat. In this case, it's the ankle that can't dorsiflex and the hip is actually just paying the price. Now you can't see the entirety of the kinetic chain during live motion. It's just too complex. That's why the assessment has to happen in a joint by joint fashion. Composite movements reveal symptoms. Prerequisite screening reveals causes. So before you load it and before you coach it, assess it. Because if a joint can't do what it needs to do, the system will find a way to cheat.